We haven't focused much this year on treatment, really, particularly medicinal treatment. But one of the major areas that you do have to learn about in medicine is pharmacology, or the use of drugs or chemicals to help treat conditions. So, pharmacology obviously is a big area, it's kind of its own course, but we're going to take a few minutes here at the end of our infectious disease unit to talk about anti-infective pharmacology. So, what are these drug-based weapons we have that we can use against pathogens? And you're going to have to apply some of this knowledge as you look at your mock patients here in this unit as well. I think Miss Peeler would really like my Leonardo DiCaprio Great Gatsby meme here, wouldn't she? Okay, so pharmacology, just quickly in a nutshell, is basically just the branch of medicine that's concerned with how drug treatment works, right? And it's actually a pretty complex area. There's a lot of chemistry involved. What you're looking at is, when to use a drug, how that drug works on a person. And so you guys are probably familiar with terms like pharmacy and pharmaceutical, right? And so pharmacology, again, just kind of has that same root. This is a big field, again. Many of, or I'd say all of you guys have taken some kind of pharmacological treatment before, right? If you've taken Tylenol, ibuprofen, taken allergy medicine like Zyrtec, if you take, stomach medicine, Gas X, something like that, you've used a medicine. Many of you probably have prescription drugs, maybe something for migraines or something like that. A lot of your parents probably have prescription medicines for things like cholesterol or blood pressure, things like that. But what we're talking about today is something else that I would bet all of you have had in your life, and that's an anti-infective drug. The majority of these things have to be prescription medicines, right? So they're not things you can buy over the counter. There's a few different anti-infective drugs you can get over the counter. Something like a Neosporin, right, would be that. But for the most part, what we're talking about here are things that the doctor could prescribe for you if you have one of these infections that we've been talking about. Now, I do want you to know two terms. This isn't super critical, but two terms that I think you should know are selective toxicity and lowest effective dose. And so basically, this slide is sort of about best practice in medicine, or best practice by doctors, right? So the first thing we talk about is selective toxicity. What this basically means is that we want to inhibit or kill the pathogen and minimize harm to our patient, right? So we want the toxicity, right, to be selective for bacteria or viruses or parasites or whatever it is. We don't want the toxicity to hurt other things. So what scientists have to do is they have to develop drugs that will specifically target pathogen features, right, and not affect the host. And that's what we call selective toxicity. So if you recall before, we mentioned that it's tough to treat fungi because they're eukaryotes like we are. And so any kind of drug that hurts a eukaryotic fungal cell is likely to hurt a eukaryotic human cell. And that's true. Right, so it's difficult to get selective toxicity with some things more so than others. Just as a side note, you can get like athlete's foot creams, antifungal creams over the counter at the store. If you look at those anytime on the labels, you got to be careful with how much you use them, because what you can actually do is start to damage your skin if you're putting too much of that ointment on, whatever kind of fungal issue you're having. Now, the second thing on this slide is similar, but also really important, and that's what we call lowest effective dose. So the best practice in medicine is to use the lowest amount or lowest concentration of the drug possible that will still be effective, right? That will still maximize death of the pathogen and minimize side effects. So in other words, kind of good rule of thumb to know just in life is never take more of a drug than you need to, right? All drugs are technically toxic chemicals. They damage cells, and so too much of any drug can be harmful to you. So always take kind of the least that you can get away with, and it still work effectively. And that's true for a doctor who writes a prescription, but it's also true for you and me when we think about taking some Tylenol because we have a headache or whatever. Um, Now, just as a side note here, sort of what's generally researched and tested is sort of like your 24-hour maximums. So you'll all probably notice before, if you look at a bottle of medicine, it might say, take 2 tablets every 6 hours, not to exceed, right, 8 tablets in a day, or whatever it might be. That's what you really want to look out for. I'm not encouraging you to take that maximum, but that's typically what you want to think about when you go to take some medicine, is just be very careful not to exceed that sort of daily dosage that they suggest. So if it says 2 pills every 6 hours, you don't want to take 2 pills every 2 hours and let that add up really quick. Okay, so we're really going to just look at 2 classes of medicines here. We're going to look at antibiotics, and we're going to look at antivirals. Now, antibiotics, I'm kind of betting you guys already know, are medicines that fight bacterial infection only. This has become fairly common knowledge, I feel like, for people. 10 years ago, it wasn't. Right? 10 years ago, people didn't really know this, but now this is more of a big topic in medicine, that we use too many antibiotics. And so now people tend to know more about this. But that's the main thing to remember. Antibiotics will only treat bacterial infection. So a lot of the things we've talked about, antibiotics won't do you any good, right? Now, there are a ton of available antibiotics out there, and they're coming out with new ones all the time too. So the list is enormous. But when we break down sort of the different antibiotics, what we look at is how do they kill bacteria? And there are different groups that we see. What we're going to take a look at kind of quickly here is there are some that block cell wall synthesis in bacteria. So if you think about that, humans don't have cell walls. So something that affects bacterial cell walls will have really good selective toxicity, right? It'll only hurt the bacteria and not hurt us. We've got some that interfere with DNA replication in bacteria. So again, their ribosome, like on this third thing here, their ribosomes are different than our ribosomes. So if we affect those ribosomes and we mess with bacterial translation, then we won't have an issue with human translation or human ribosomes. And then we've got other ones that attack bacterial metabolism, prokaryotic metabolism, which again, since we're eukaryotic, that doesn't tend to hurt us too much. Sorry for all the background noise on this slide too. I have no clue what is going on in the other parts of my house right now. All right, so the first group we're going to look at here are called beta-lactams. And beta-lactams are a large group of medicines. There's really about 40 different drugs in this beta-lactam group. And what these do is they stop peptidoglycan production. So if you remember back to structure earlier in this unit, peptidoglycan is one of the components of the bacterial cell wall. Now, the classic antibiotic comes from this beta-lactam group, and that's penicillin. You might recall from way back at the start of the year, Alexander Fleming made his discoveries in 1928 that led to the production of penicillin from a fungus called Penicillium. Today, we have a number of penicillin derivatives, so medicines that kind of come from penicillin and have a very similar structure and a very similar activity. And a lot of these have become more common than using penicillin. The cool thing is penicillin is still effective. Honestly, penicillin against something like a basic staph infection or a basic strep throat is still one of the most effective drugs that we've ever discovered. So pretty cool that they still use penicillin every once in a while. But penicillin too is an injectable, and that's not what most people want nowadays. Like this poor little kid up here getting his penicillin shot in his backside. Today people typically want liquid or pills, and so these other ones are made for that. So we got things like amoxicillin, which has the trade name Amoxil. There's also oxacillin, there's cloxacillin, there's ampicillin, there's methicillin, there's dapsillin, there's a whole bunch of these. Again, all of these are really effective against gram-positive bacterial infections. So if you see a patient that has one of those things that we talked about, right, Staph aureus, strep pyogenes, of the skin, or a strep throat type infection, you would use a penicillin type drug or a penicillin derivative. Biggest side effect here, there aren't a lot of side effects to this drug. The problem, sometimes not considered really a side effect, is that some people are allergic to these. So there's a decent shot that one of you guys out there or more is allergic to penicillin type drugs. And if you're allergic to one, you're allergic to all of them. So if you have an allergic reaction to amoxicillin, you're going to have an allergic reaction to all of these. But otherwise, not a lot of side effects, very effective against gram-positive bacteria like staph and strep. Now another group, or another type of beta-lactam, are called the cephalosporins. Cephalosporins are a pretty strong antibiotic. A lot of times they're referred to as a broad-spectrum antibiotic, as we saw in our little lab-like activity that we did. These can be effective against a wider array of bacteria, so not just gram-positive or not just gram-negative. So these are effective or useful if a doctor doesn't really know exactly what pathogen they might be fighting. Right now, it's typical that a doctor will prescribe the medicine that is most likely to help you. So for instance, they might not have a confirmation that you have a strep infection, but if it looks like strep to the doctor, he or she's probably going to give you a penicillin derivative drug. So that's usually what you go for. But maybe there's something that the doctor can't quite figure out. Maybe somebody has a sinus infection that just keeps on, and they don't know exactly what could be causing it. Well, they might give a cephalosporin type drug, right? Because this can be effective against both gram positives and gram negatives. These are also useful if the patient is allergic to penicillin. Right, is where you might use a cephalosporin drug more likely. And so these have several different names too. They all have ceph in them though, right? So ceftonir, cephalexin, cefaclor, ceftazidime. My daughter Charlotte is actually allergic to, had an allergic reaction to amoxicillin. So when she goes to the doctor, she tends to get something like ceftonir if she has strep throat or something like that. Now there's also interesting combo drugs when it comes to beta-lactams. Sometimes drugs are combined together into basically one pill to create a broader spectrum antibiotic, something that is more effective at killing a nasty infection. The problem is that a lot of times combo drugs like this do have bigger side effects. So one of the most commonly prescribed combo antibiotics is called Augmentin. And Augmentin is a combination of amoxicillin and clavulanic acid. Now, Augmentin is often prescribed if someone has an infection and they're given something like penicillin and the infection still doesn't go away. Then you might try Augmentin. Also, if a patient seems particularly miserable, a lot of times doctors, particularly at like immediate care center type clinics, might prescribe Augmentin. The thing about Augmentin is it is notorious for giving you stomach side effects. I've had Augmentin once in my life and it made me really sick, made me throw up. So I stay away from it now. And maybe you all have had a similar experience, or maybe not. But that's what Augmentin is like a combination of a penicillin drug with another one. Now our second group, so moving out of the beta-lactams, are called the macrolides. And macrolides inhibit bacterial translation. So they sort of mess with the bacterial ribosome, which again shouldn't have really any effect on your cells, but it should really kind of screw up the bacteria if they can't make proteins at their ribosomes. One of the most common ones of these is called azithromycin, which has a trade name of Zithromax, which most people just call a Z-Pack. If you've ever had a Z-Pack before, these are also highly effective against gram-positive sinus infections. So usually different types of strep that people might get a sinus infection from, you might use a Z-Pack. Z-Pack's nice because it's effective, it's quick for a lot of people, and so while it is a little slightly more expensive usually than getting something like amoxicillin, Z-Pack is usually pretty effective against those similar types of infections. Third group are called the quinolones. The quinolones are also one that we'll tend to see allergies to. But the quinolone antibiotics function by messing with some of the kind of accessory enzymes of bacterial replication. So we didn't go into a lot of depth in this course about DNA replication, but what these do is they make it so bacteria cannot copy their DNA anymore, so bacteria can't multiply, right? The most common here is Cipro or ciprofloxacin. Levofloxacin is also common. There's some others as well. Typically we just refer to this as Cipro. Ciprofloxacin is highly effective in fighting gram-negative infections. So again, the majority of urinary tract infections are caused by E. coli, as we've learned in class. And so Cipro is your number one drug prescribed for UTIs. Now, the one thing about these drugs is that they're only prescribed to adults. So if you see a kid who has a urinary tract infection, you have to go a different route. The quinolones actually sort of interfere with cartilage development. And so for adults, it doesn't really matter. You already have all the cartilage and bone you're going to have. But in kids, there's still a lot of cartilage in their skeleton as their bones develop. And so if you give kids quinolones, and as you might guess, they found this out the hard way many, many years ago, you can stunt the growth of their cartilage and therefore stunt growth of their bones. So Cipro, the go-to for treating UTI, but only in adults. Now, because we bring that up, I bring up this fourth group, the sulfa drugs or sulfonamides, and there's a very similar drug called nitrofurantone. These are antibiotics that mess with bacterial metabolism or metabolic enzymes, which again are going to be a little different than our human ones. These are also used for UTI, but not as commonly as something like Cipro. Sulfa drugs are more common in kids, or more commonly used in kids. That's what you would go to if you had a child patient with a UTI. Nitrofurantone especially also is used for a lot of preventive or what's called prophylactic prescriptions against recurring UTI. So if you have a patient who for some reason or another just keeps getting urinary tract infections, you might actually put them on a long-standing kind of low dose of nitrofurantone, which will help ward that off. Also, a lot of times we see this in older people. Sometimes my grandfather included. Sometimes when people get particularly old, they struggle with bladder control and things, and so they may actually end up with a catheter, even right, a tube that helps them relieve their bladder. And if you got a catheter in there, that can easily get infected and things. So if you place a catheter in a patient like that, a lot of times what you might do is prescribe a dose or kind of a recurring low dose of one of these drugs to help keep that infection from happening. Now, the last couple slides here, there's not much to say, is about antiviral medication. The thing about antiviral treatment is there's very few of these drugs on the market. If you think back again to what we learned in this unit about structure, Viruses are obligate intracellular parasites. They must get inside your cells to be effective. And that means that once they're inside your cell, it's very difficult to access them and kill them without harming the host. It also means that those reproductive stages that we might want to target, right? DNA replication, protein production, that kind of stuff, that's all performed by your cells. It's not performed by the virus itself. So it becomes very challenging for researchers to come up with ways to attack viruses. And so, for the most part, viral infections cannot be treated, right? Particularly not with medications. Something like the common cold, something like the flu, although we'll come back to that in a moment, something like a viral sinus infection. These things, you just kind of had to let it run its course, right? And what you try to do is you try to treat the symptoms. So you take Tylenol or ibuprofen for a fever. You take, some sort of decongestant medicine or, Sudafed or something like that to help you don't not feel so bad. But when you take those symptomatic medicines, something like NyQuil or, like I said, Sudafed, Dimetap, those things, they might help you not cough, might help you not ache, they might help the fever go away, but they're not actually getting rid of the virus, right? They're just helping you feel a little bit better as your body copes with it. So for years, the main way to quote unquote treat viral infection is vaccine or a prophylactic approach, right? A preventative approach so that you never get the viral infection to begin with. And so we've mentioned a little bit about vaccines so far, but common ones that we've brought up: MMR vaccine, HPV, VZV, and of course there are others too that we get when we're little kids and then throughout our life. Couple exceptions though, couple examples, and again, there's not a whole lot of examples for this. There are some antiviral drugs that have been developed that can block a virus from getting into your cells. And if you can block the virus from getting into your cells, then you can at least somewhat decrease the number of viruses because you can decrease their ability to multiply. So a couple examples. One is herpes, right? HSV, herpes simplex. These are more about control. So I'm going to write here, controlling symptoms than it is about getting rid of the virus. Like you notice in this first bullet here, the symptoms of active herpes infections can be treated, meaning we can treat the blisters, we can help the blisters go away, but we cannot eliminate the virus. So we don't have a medicine for that. But you've maybe heard of Valtrex before or Zovirax. These are cyclovir drugs. So there's valacyclovir and acyclovir. That's what these do is they help if you have symptomatic herpes. They help get rid of those blisters and those outbreaks. But they don't remove the virus from your body. So it's sort of a treatment, but certainly not any kind of curative treatment that we can see. There's some fun old commercials about this, right? About Valtrex and stuff, where there's like this guy and he's just like, I have genital herpes, right? And then it goes on to be a pharmaceutical commercial. But yeah, so there is an option at least there. I mentioned flu a moment ago. And influenza is an interesting and sort of more recent idea here. There are now a number of medicines, we're going to mention two here, but there are a number of medicines that can be prescribed for someone who's diagnosed with the flu. Just like those herpes medicines, these do not cure the flu. They don't eliminate the virus, but what they help do, again, is sort of help control the flu. Now, what these drugs can do is they can help prevent you from catching the flu from someone. So you maybe prescribe these to a parent if their kid has the flu, or to a sister if her brother has the flu. They also, if you administer them early on, can lessen severity and length of symptoms. So hopefully decrease how bad your flu is. But you do have to get it right at the beginning of the infection for them to be effective at all. The one you've probably heard of before is Tamiflu. Tamiflu is the trade name for a drug that's chemically known as oseltamivir. There's another one that you maybe haven't heard of as much called Relenza. Relenza, as you see in this picture, is actually an inhaled medicine. It's called zanamivir, technically. And, these drugs, again, they're an interesting case. I'll be honest, I've never had them before myself or never taken them. When we look at Tamiflu in particular, Tamiflu you have to take within the first 2 days of the start of flu symptoms, or else it doesn't really do anything. And it is scientifically shown to shorten your flu by about 1 day. And on top of that, it's kind of expensive. And some people have said that it has really bad side effects. In fact, I've heard before that the side effects of Tamiflu can be just as bad as having the flu. So there's a big question here, right? There's a big cost versus benefit question here. A lot of people swear by it. A lot of people really believe in it. And when I say that, I mean doctors and patients both really, really believe in it. But to me, it seems a little odd to have a medicine that might cost you a lot of money and still make you feel kind of crummy, and then it just shortens your flu by 1 day. So I don't know. Well, I'm on this too, just to bring it up again. We can't typically treat the common cold, nor do we need to. So it raises an interesting question right now, which is, what about COVID-19? And you guys might have, heard different things out there. The official statement from the CDC right now is that there is no, medicinal treatment for SARS-CoV-2 infection for COVID-19. So typically we would just say there's no treatment. There are a couple medicines they're using somewhat experimentally. Basically, they're throwing any kind of antiviral medicine they can at this just to see if it works. So there are a couple now. There's sort of a protocol of this kind of combination of 2 drugs that might help people. Also, same idea, just trying to treat symptoms. So in severe cases in the hospital, doctors are prescribing steroids, corticosteroids, to help reduce sort of the immune system's reaction to it and help reduce the symptoms. But as of right now, if you get this, it's just kind of like other colds and flus. There's not a whole lot we can do to treat it. Just try to weather the storm and ride it out. Last thing to bring up is HIV. Again, HIV categorized as untreatable 20 years ago. But today, there are a number of different drugs, in fact, there are lots of them, that can help slow down the progression of HIV. So again, if you contract this, you're HIV positive, and then over time, that could develop into AIDS. So the goal of treatment here is to slow this down, right? Or prevent the person from ever transitioning into actual AIDS, where their immune system is really, really struggling. So again, it's not a cure, right? It's all about, again, control of the infection. This can be really expensive, and also involves taking a lot of drugs, a lot of medicines into the body, which can be a little bit dangerous or damaging itself. But what we use, and this is what I want you guys to know, so if you see a patient with HIV on your mock patient stuff, you would say that you would treat them with HAART, HAART, which stands for highly active antiretroviral therapy. You do not need to memorize any of these guys, but these are just a few of the drugs, and they all have these little abbreviated names that we use against HIV. And what typically these people will have is a cocktail, so a combination of drugs. And this will be unique, and it will be changed after short periods of time usually. So someone might take, let's say, these 2 drugs for a month, and it appears to be working well, and so their doctor keeps them on them for a second month, and at the end of that second month, they do a blood test, and it appears that the medicine's not working anymore. Well, then they might switch, right? Then they might go with AZT and this T20 thing and try that. Or maybe they'll go, use these 2 instead. And so this is something that's somewhat experimental for each patient individually. But combinations of these drugs, called HAART, can sometimes be effective. So I know that's a lot to take in. I think this is enough pharmacology to serve us in terms of what we're going to do. And so I hope this maybe helped you learn a little bit more about medicines that maybe you've taken before, and then that you can apply this well to our activity we're going to do in class.